Zero. None. We now have a program where we have not one, not two, but 8 stroke neurologists serving us every day. We now have a program where we have cerebral vascular surgery here every day. We now have 3 interventional, 4 endovascular nerve surgeons every day. We now have transitioned our ultrasound, TCD, which was done in radiology and wasn't done, to now having vascular specialists. It's been a wild ride. I was here before the first conference, I spoke at the first conference, and I'm absolutely delighted to speak at this conference, but not because I like getting up and talking to you, because for me, when I look back at what's happened in this community, not only at St. Luke's, but at St. Al's, we have upped the game for cerebral vascular care, as well as neurologic care in Idaho. And that's why I came here. So it's a real pleasure to talk here. It's a real pleasure to have the vascular technologist talk here in front of arguably one of the persons that pushed transcranial Doppler from sort of a sideshow to a mainstream event. I mean, it's really cool. So what wasn't said is we used to do transcranial Doppler, and we didn't even have any images. It was all done by ear. And we now sort of have all of this stuff. Now, I'm an interventionist. I love to show wild, crazy things because that's what I do. I do procedural-based medicine. That's what I do. But I will tell you, whatever I do represents 10% of any care. I mean, it's trivial. What you guys do carries the football across the goal line. And I think that that's sort of the thing that needs to be reconciled in this room is, yeah, the slick, cool stuff that we do is cool. The reality is the daily work is what you guys do, and that matters. Now, having said that, when we look at cool new stuff, don't forget the old stuff, because time is evolving. So that's what I'm really going to talk to you about is CSF diversion and subarachnoid hemorrhage. There's nothing sexy about this for an interventionist. Nothing. So, I have no disclosures. I don't work for anybody. I didn't use AI. I didn't cheat. You know, this is now a big deal for me because I have daughters that are in school. Now, I'm going to quickly go, I'm going to blow some of this stuff because it's been covered. But subarachnoid hemorrhage comes with a bunch of things. Hydrocephalus, vasospasm, what's called delayed cerebral ischemia, cerebral infarction, death. It's the real deal. And what you guys do can impact the outcomes of these patients dramatically. Now, again, I don't want to belabor this, but I'm going to just comment that the pathogenesis seems to be related to the encasement of these blood vessels in clot. So there is something really important about the extracellular location of what in mediating this. The second thing is that, yes, there are differences. Not everybody gets vasospasm to the same. Some people are more predisposed, increasing age, higher Hunt-Hess, so that is if your neurologic score is worse, it's worse when you come in. Hypertension, diabetes. So there are some concomitant conditions that set you up at higher risk. Younger patients, younger women, young women seem to get vasospasm really bad. Why? We don't exactly know. Now, what I really want to talk to you about is delayed cerebral ischemia. It used to be thought that it was entirely related to vasospasm, and that is not true. So now we're beginning to have a more insightful sort of understanding. Vasospasm is important, and it contributes dramatically to neurologic injury. I am not trivializing that, but there's a little bit more. And a little bit more is probably, we're just beginning to talk about this a lot at the sort of local level, but it's multifactorial, and probably the most important thing, I'm sorry for misspelling on the slide, but microcirculatory dysfunction. We actually can see that reflected on TCD. you can actually see sort of the pulsatility in these sometimes go up and everything looks normal, but the patient's looking worse. It probably is related to microvascular dysfunction. Lymphatic impairment, what the heck is that? Your brain has a lymphatic system. It has a lymphatic just like everywhere else. It's been ignored in the setting of neurologic injury for years and years and years, but now it's coming to the forefront. So that sort of is involved. Inflammation. And then there's the neuroelectrical disruption and depolarization that occurs. So it's a big deal. So what's the inciting factor? The inciting factor is subarachnoid hemorrhage. But if you look, you have a subarachnoid hemorrhage, your blood pressure dramatic, and your head suddenly goes, your intracranial pressure suddenly goes way up. You have transient global ischemia. You then sort of get the sympathetic nervous system activation, and then it results in some vasospasm. You get endothelin 1 expression, that increases vasospasm. So that's one side. This is the vasospasm side. This is the other side. And that's where delayed cerebral ischemia can come into play. So is there anything we can do about that? Absolutely. That is the role of, that is probably the role of when we're giving amlodipine. That's where it probably acts. There's other things we do. For example, we'll give a statin. Everybody goes, why are you giving this person a statin? There have been trials that have looked at statin and reducing or improving outcomes. It has not been impressively positive yet. However, this is probably just the beginning. So why do we give statins? Because they have a predominant inflammatory action, not to lower the lipids. We do stuff where we want to increase the magnesium. Why do we do that? It probably affects the microcirculatory environment. Why do we want to keep the sodium 135 to 145 and strict? Because we don't want shifts across the cellular membranes, which probably impacts the left side of this slide. So, let's think about CSF circulation. Well, what you may or may not know is historically what we do is put an EVD in. Why do we do that? Well, you bleed in the subarachnoid space, you have impaired resorption of CSF through the arachnoid villi, and which, maybe I can do it here, through these sort of channels. But the other thing we'll do is we'll put an EVD in to lower intracranial pressure, divert CSF. And we put that right into this area, right here. But importantly, the production of CSF is right through here. These are in the choroid plexi and down here, etc. But if you notice, the production of CSF goes through here, through the aqueduct of Sylvius, out through the plane of Lushka and Magendi out here, circulates around, it goes down into the spinal column way off the slide here, and then back up, and then it's reabsorbed. Now I want you to keep that sort of concept in your mind. And why is that? Because historically we've put in EVDs or ventriculostomies, depending on how old you are, to divert CSF. So we're diverting CSF where? Directly where the CSF is produced. Now, why does the CSF turn red in the EVD, you might ask? It's because the CSF flow is not exactly linear forward. It's a pulsatile flow, so there is some mixing. So some smart people decided, well, maybe we could rethink about this differently. Maybe we could divert CSF differently, and maybe that might do something. And so there are some early trials that looked at it, but most importantly, there's a trial called the Early Drain Trial. The clinical question is, if we have patients with aneurysmal subarachnoid hemorrhage, can we drain CSF compared to standard therapy, which included EVDs as well, improve clinical outcomes measured by a standard measuring tool called modified Rankin score at 6 months. So that was the question. And the thought was, well, maybe we can affect the left side of that slide I showed you earlier. That is all the microcirculatory dysfunction, the electrical depolarization. Could we perhaps maybe remove more blood? Because we're actually putting a catheter where the blood wants to go anyway by CSF flow, as well as what people don't realize is blood is heavier than CSF, so it will want to gravitate down into your lumbar spine. So the hypothesis was we could preferentially remove more blood, and we had some retrospective data and meta-analysis of lumbar drainage use that demonstrated some improvement, but we also had a trial out here that suggested that we could lower rates of DCI, but there was no change in neurologic outcome. So this was a trial which was then sort of designed with a number to treat of 300, which was what was statistically required. And so what they would do is they would manage these people, and this is called a pragmatics trial, which means that they didn't tell centers to change their standard practices, they were just adding one more tool. So they added a lumbar drain to best medical management. They placed after the aneurysm was treatment, in addition to EVD if it was placed. They, in general, took approximately 5 mLs off per hour for 4 to 8 days. Patients with lumbar, it turns out that patients with lumbar drains did have lower ICPs and EVD amount. So, in fact, not only did this lower or remove potentially more blood, but it actually lowered ICP. How did it do that? Because during aneurysmal subarachnoid hemorrhage, you will have pressure waves where you'll see people's ICPs go up. So they had less pressure waves, is what they were saying, and less ICPs greater than 20. Patients with lumbar drain had less cerebral infarctions, but similar severity of vasospasm. Again, this is only, vasospasm is only part of the question. But patients with lumbar drains did have a lower likelihood but unfavorable neurologic outcome. It was statistically powered. So this has been a little bit of a game changer trial. Not quite as powerful. We didn't get a plethora of 5 of them like when we did the thrombectomy trials, but this is sort of a game-changing sort of strategy. Now, great, it works. But what happens if you actually say, hey, can we get the blood out faster? Can we remove blood more efficiently? Hence, what can you do? You can add TPA. Now, TPA is a great drug in the veins. It's a great drug in the arteries. It's also a great drug in the CSF. So what can you do? So if you have a large volume subarachnoid hemorrhage and you have a relatively slow rate of clearance of clots, could we get the clots out faster? EVD and lumbar drains allow access across the blood-brain barrier. They allow access to forgiveness. TPA doesn't cross the blood-brain barrier. And a lot of drugs don't. So I can tell you while we're using TPA now, if you have a lumbar drain or an EVD, you are going to create another environment where we can actually add neuroprotective drugs, etc. 5 minutes. Wow. That's like, I'm going to get like a 10 score. 5 minutes, but I'm going to. But at any rate, what I was going to say is that this is just the beginning of sort of an evolution in sort of the strategy of how to treat this. Now, there was a meta-analysis of using what I call CSF Diversion Plus, which is using the introduction of lytics. In a meta-analysis of 9 randomized clinical trials, 12 non-randomized trials, we get intracisternal, so that's through the lumbar drain. Fibrinolysis significantly decreased poor neurologic outcomes. It reduced delayed neurologic injury and reduced chronic hydrocephalus and subsequent death. So what has happened is we are beginning to transition yet another tool in our quiver to move the barometer of how we take care of these patients. So instead of them having a mortality of 90%, which is what they used to have, to 70%, to now mortality is different. And patients actually are likely to have better neurologic outcomes. We're moving the bar, and it's all because of this block and tackle, unexciting from my perspective as an interventionist, but most importantly, the most critical part of care for these patients. So what do we do here? We actually do things a little different. That shouldn't surprise you. We actually put the lumbar drain in prior to treatment for the aneurysm. So the patient rolls in, they're neurologically stable if they go in the ICU. As long as they don't have a high risk of obstructive hydrocephalus pattern at the foramen magnum, they get a lumbar drain. That's placed below the forehead. Why? Because we use all sorts of crazy drugs like antiplatelet agents, etc. So we put it in ahead of time. Secondly, if you rupture the aneurysm, God forbid, you actually have given yourself a safety net. So that's what we do. So we put a lumbar drain in. When we place it, it's clamped. Once we treat the aneurysm, we have initial drainage of 10 mLs an hour. If the aneurysm is secured, we do a CT in the morning. If they're awake, it's easy to monitor for overdrainage. If they're not, they're going to get routine CT scans done. The next morning, we remove an additional 10 mLs, and we actually introduce 4 milligrams of TPA. Why 10 mLs? Because when you dilute the TPA and you inject it back in and flush it, you use 10 mLs. We let it dwell for an hour, and then we start to resume drainage. We repeat this 3 more times. So typically, you'll get four doses. After the 3rd dose, if they haven't had a CT, we'll do a CT. If we can visibly see the subarachnoid hemorrhage, we continue. If we can't, then we stop. We obviously adjust if there's overdrainage, if the patient has increased headaches, etc. And the drainage, we then just slow it down. And then if an EVD is placed, monitor your ICDs from the EVD, the drain from the lumbar drain, because that's where you're going to get the most blood. So this is where I think the next step of evolution is for treatment of subarachnoid hemorrhage. It is not to treat vasospasm, it is to treat really delayed neurologic injury, but does it help with reducing vasospasm? We don't know with the TPA model yet, because that trial is not done, but I would argue that this just represents another tool in our quiver. We used to float Swan-Ganz catheters, put Swan-Ganz catheters in ruptured pulmonary arteries to treat subarachnoid hemorrhage. We don't have to rupture any pulmonary arteries anymore. We've sort of dialed that back. That's been an evolution. We now do TCD monitoring here daily in our ICU for subarachnoid hemorrhage, yet another sort of quiver in our thing. And I would argue, you might not say it's the gold standard, it's the only thing I care about. Because if I see TCD numbers going up and the patient's neurologic getting worse, I don't care what the angiogram shows at that moment. It still initiates a whole host of interventions that we do. So even though I do angiography, I'm the guy that does it, just so you know, TCD does represent my management gold standard on a daily basis. So with that, I have nothing more to add. Thank you guys all for coming. Thanks for building this thing we have here, because it couldn't have been done with just people like me. It was done with people like you. Thanks for showing up. There's 170 of you here now. On our first conference, there were 70. That speaks volumes. Thank you for those who are in the same house, because our responsibility is to take care of Idaho. Thank you for those who come from other hospitals, because Idaho is what this is all about. So anyway, thanks again. It's been a great journey.